Hi, everyone. My name is Fabio Moraes. I'm a radiation oncologist, assistant professor, Department of Oncology, Division of Radiation Oncology, Queen's University in Kingston, Canada. First, I'd like to thank the organizing committee for this invitation. It's my pleasure to be here today, and I'll be discussing and presenting on Choosing Wisely Brazil Oncology Task Force. First, my disclosures. I previously received some honoraria from AstraZeneca. They do not are represented here on this project, so I have no conflicts of interest to describe regarding to this current project. So as some of you have already learned or listened or read about Choosing Wisely, so Choosing Wisely is a campaign which is aimed to identify low-value, unnecessary, or harmful cancer services that are frequently used in national healthcare system. With Choosing Wisely, we want to ensure high quality and affordable cancer care while we avoid unnecessary tests, procedures, and treatment. Choosing Wisely was funded on the success of the campaigns in the US and Canada, and more recently has expanded to Africa and India as Choosing Wisely Cancer. Then one of the objectives here is to start the dialogue and to make sure that we facilitate quality improvements initiatives through measurements and performance reporting. So as I said, there are some previous efforts outside the US and Canada, and here I highlight two important ones. The first one that I want to highlight here is the Choosing Wisely Cancer India that listed the top 10 oncology, that published a top 10 oncology list of avoidable or low value practice in the region. And also the Choosing Wisely Africa that was led by my colleague Fidel Rubigumia, that also had a top 10 list that was endorsed by aortic and other oncology societies in the African region. So as I was explaining, Choosing Wisely is a cancer campaign to enable the development of evidence-based, context-appropriate guidelines for measurement cancer. As we all seems to understand that this is obvious, an initiative like this one has no precedent in Latin America. So that's the reason we thought about doing this project. But why cancer? So we decided to work with cancer first because cancer treatment is complex and its economic impact is an important issue affecting a lot of countries, including Brazil. Many medical practice does not offer benefit to patients, and sometimes they can have a negative impact on healthcare and budget. So it's imperative that we understand and map these low-value services to promote better care to our patients. On this scenario, for you that I want to read more about what is happening in oncology and what we want to see in the future. So this paper on the common sense revolution in cancer care, led by my colleagues Bishal Gawali and Chris Booth, is a very important piece that shows that we need to focus on treatments that benefit patients, and we need to understand how to do this and how to do this better. So let's go back to the Brazilian Choosing Wisely, the Oncology Task Force. So with that project, we aim to identify a list of cancer practices that are frequently used in the Brazilian healthcare system and that are considered low value, unnecessary, or harmful. In the end of the day, we develop a top 10 list of cancer Choosing Wisely Brazil, and that list should be used, reviewed by clinicians, patients, cancer systems, decision makers. So how we managed to develop the project? So first, we put together a task force. So the task force included medical oncologists, radiation oncologists, surgical oncologists, palliative care doctors, and patient advocates. We also had a project advisory team, which we had most of the specialties represented there. Regarding the methods, so we followed a specific methods that has been previously reported. So first, we identified the task force, which was the most important, one of the most important tasks, identifying leaders in the field that understands the problem in the region like Brazil, that understand the importance of high value care, and that are open to discuss and to be very honest on what we are doing wrong and what we can improve. So after identifying the task force, we had an introduction teleconference where we discussed the aim of the Choosing Wisely Brazil. And then after that, we start working together to put the long list. So we went after all other previously published Choosing Wisely to see what is already available, what has been discussed as a low value practice. So then we did the online surveys. So people were debating and choosing what is appropriate for the Brazilian context. After that, we actually went for a teleconference discussion and voting. And then from a long list, we went to a short list. And then we had more online surveys because we started with hundreds of potential recommendations and we had to end up with only 10. So then we kept going with online surveys and telephone conference and voting. And then we had a final draft list. With the draft list, we developed supporting summaries and we add the references to all that recommendations. And then we had a final online survey. And then we work with major organizations to get endorsements. So as I said, we started identifying a long list. So how we do that? So we reviewed the previous Choosing Wisely list. With all that available recommendations, we actually categorize them into items: diagnosis, treatment, screening, and palliative care. And we also include new practice on the list plus supporting evidence. So we always, in every single step of this process, we asked our task force to bring forward or recommend any new practice. So from the long list, we went to a short list, and then from a short list to a list of deliberation. So it all involved literature review, discussion of the context, if this is important for the Brazilian context, and if this is a practice that is really frequent. And in the end of the day, we would vote to make sure that everybody was happy and in agreement that that recommendation should be included. And what were the criteria that we used to select those practices? So number one, evidence of low value or harm. Two, high frequency of use for the Brazilian context. Three, cost, including opportunity cost. Four, clarity on the wording of the practice item. Five, relevance to the Brazilian context. And six, feasibility of future measurement activity. So a consensus agreement was reached to include or exclude all practice items that we discussed in every single call. So we gave opportunity for everyone to participate, for everyone to give their opinion. So that was a very open and democratic process, aiming to find the top 10 list that of cancer practice that should be avoided on the Brazilian context. So here is just a print screen of the paper that has now been published. So has been published at Nature Medicine. And here is the link if you are willing to read it and to understand better our work. But I'm gonna go through the list and also the next steps here on this presentation. So on the next couple of slides, I will go and I will review every one of the recommendations. So I'll be discussing the 10 recommendations that we listed and we agreed that should be avoided on the Brazilian context. So the first one that I want to highlight here, so there's no hierarchy here, which the first could be the 10th or the first could be the 5th. They're all equally important. So number one that I'm discussing here and that we agreed as a group is that it reads as don't neglect to address lifestyle factors such as smoking cessation, exercise throughout the patient cancer journey. Why that is important? Because we found out that in a lot of cases, physicians and healthcare allied professionals would be very much focusing on treating the cancer, understanding the cancer, but they actually forget to address and stress the importance of factors such as stop smoking or exercising or have a health diet during the cancer journey. So as important as treatment, promoting health or preventing further problems is also very important. The second one that I want to discuss here is don't perform screening diagnosis tests in asymptomatic or average risk patients. So this is something that we found to be an important issue in Brazil, was that many patients were being subject of screening a test only because they were at the doctor or they were seeing doctors. So we commented against those practices. The third here is don't use surgery as the initial treatment without considering pre-surgical neoadjuvant systemic or radiation for cancer types and stage where it is effective at providing or improving local control, quality of life, or survival. So important here to highlight is that we are here pushing for a more multidisciplinary care of our patients, and that sometimes surgery should not be the first initial treatment, and there are other treatments that should be discussed with the patients before they engage on a major surgical procedure. Don't order screening or routine chronic disease testing just because a blood draw is being done. So this is important to be highlighted because there is some data from the country saying that about 30% of blood draw or blood tests are not being checked, majorly because patients are getting extra tests just because blood is being drawn. For instance, if they're doing a hemogram, a regular hemogram to check platelet levels or white blood counts. In a lot of the cases, doctors would add, or the patient would ask to add TSH, T3, and other investigations that were not supposed to be happening. Next one is don't use target therapy intent for use against a specific genetic aberration unless a patient's tumor cells has a specific biomarker that predicts an effective response to the target therapy. This is very important because we know that most of the target therapy, they have a specific genetic aberration that needs to be present so we can see the maximum benefit of the therapy. And has been described that there was some misuse or broader use of this kind of therapy in the Latin America context. Another one is don't routinely use standard fractionation scheme, more than 5 fractions for palliative uncomplicated radiation to bone metastasis. So this is important that we know we have evidence for a single fraction for uncomplicated bone metastasis, and using more than 5 fraction has not been proved to be superior to other kinds of fractionations with 5 or less fractions. So, and this was found to be an important issue in the country, as there is reports of single fractions being underutilized in the country. Don't treat low-risk clinically localized prostate cancer without discussing active surveillance as part of the shared decision-making process. Again, here is highlighting the need of multidisciplinary discussion and also bringing forward the importance of sometimes not treating the patient with invasive procedure, but actually promoting shared decision and promoting a surveillance when necessary. Don't routinely use extensive local regional therapy in most case situations where there is metastatic disease and minimal symptoms attributed to the primary tumor. So again, here is it could be a potential issue of overtreatment. Sometimes has been described that we are using extensive local regional therapy on situations that the benefit could be minimal or even could be no benefit. Another recommendation was to don't initiate therapy for patients with inoperable early stage non-small cell lung cancer without discussing stereotactic body radiation as part of the shared decision-making process. So it was found that there was an important gap here, in that patients with inoperable early lung cancer should be offered, or at least should happen to participate on the decision on which treatment would be the best for their cases. And last but not least, don't use cancer directly therapy for solid tumors patients with the following characteristics: low performance status, no benefit from prior evidence-based intervention, not eligible for a clinical trial, and no strong evidence supporting the clinical value of further anti-cancer treatment, with focus on symptom relief and palliative care. So this is also important for us to try to avoid low value practice here. So we are only going to be promoting or discussing the use of direct cancer therapy for patients who could potentially benefit from that. We always need to remember that therapies, they are associated with potential side effects, and the side effects can decrease quality of life. So what we expect to be the impact from this work and this list is actually to help to promote high quality cancer care in the country, to offer insights into how to optimally deploy the available resources, and to ensure that the maximum public health benefit for the country and for the region. We need to remember that access to care and the budget on the public health system is always limited. So we need to use it in the best manner possible. And finally, we want to serve as an example for both Brazil and Latin America, so other disciplines and other countries could also start their own movement. So what are the next steps that we are planning now that the list is published? So we want to understand how we can implement, evaluate Choosing Wisely in every single physician practice or health system. And for that to happen, we need to focus on knowledge translation. So we know that study shows that it takes an average of 17 years for our research findings to be incorporated into practice. And that only about 15 to 20% of research findings ultimately had widespread adoption. So we need to try to bridge the gap between research and implementation. So that's what we are gonna to do here. So when we are trying to do knowledge translation, there's 4 big steps. The first one is the synthesis, so it's the aggregation of research findings on a specific topic. So that's what we are doing here. So we did the synthesis of information, and now we have a list. So second point is dissemination. So it's the process of spreading the findings throughout message that would reach a specific audience. So we were working with that. So we had the paper published, we have some commentaries on some local journals, and also we were working with hospitals to promote the lists. Next steps that we are planning for the future is the exchange phase, which is a multi-directional flow of information between researchers and the users. So now we are going to be connecting with like decision makers, practitioners, and patients to see what they think about the list, what should be added, what should be improved. And then last but not least is application. So how we are going to evaluate if the list is being useful, or if the list is translating to any impact to that health system. So for that, we also have the end of grant of knowledge translation and the integrated knowledge translation. So on these 2 phases, so the research will develop and implement a plan for making knowledge users aware of the research findings, and we are already doing that. And the knowledge users are going to engage with us as equal part to help us to implement, to learn, and to make our list better and more useful in the future. For dissemination, so we were working with endorsements. So we have endorsements from the major societies of oncology, radiation oncology, surgical oncology in the country. We are working in promoting in annual conferences in the country and in the region. We are promoting our work with physicians group or with health systems decision makers, and we are also planning for more manuscript publications. We are also now planning and going forward with some additional surveys. So surveys that are going to be aiming to understand the knowledge and the usefulness of our list. And the surveys are focusing on hospitals, healthcare professionals, patients, and also our overreaching community. And then the next step would be implementing. So it's what we call implementation science. So there's four important steps here. First one is exploration. So that we go and we assess the needs and capacity to implement. We identify barriers and facilitators. So we are working with potential 2 hospitals to start doing this exploration phase. And then after, we want to do the installation, which is plan and prepare for implementation. So actually bringing the list to clinics and making sure that everybody is aware and it's reading the list before giving any final management plan to their patients. And then we have initial implementation, that is implementation and testing, monitoring and evaluating, and then refining how best implement the list. So it could be having a list of the clinic, it could be giving rounds every morning, it could be giving rounds about the list every couple of weeks or months. And in the end of the day, we want to go for full implementation, which is a sustainable and scalable implementation across different settings, hospitals, and regions of the country. And for all of that, we need to do measurements, which is the science of moving research into policy to practice. So for you to actually impact policy and practice, you need to measure, because only what gets to be measured gets to be managed. So then we are going to measure the impact. We're going to measure how the Choosing Wisely Brazil list will change and improve practice and potentially impact policy in the country. The future here is where we want to come from the knowledge, what we develop, and then we go through all these ways of implementation that we can call the black box of implementation. We'll need to understand barriers, facilitators, how it's sustainable, what is the biggest problem that people are aware or not aware of. We need to learn if this makes sense for other regions of the country, for other stakeholders, and then potentially that will be applied to practice, and that would potentially change and impact practice. So it's a long run. So the list is just a beginning of what we're planning to do and what we are doing now. And hopefully I'll be able to share more results and share like impact in our region in the future. So thank you. I want to highlight that this project would not be possible without my collaborators and my co-authors, and they are listed here. So if there's any further questions, you can find me on my email or Twitter. So feel free to reach out. I'll be happy to answer to your questions. Thank you and have a great meeting.